Okay, we're going to go ahead and get started. Thank you everybody for coming today. My name is Carolyn Merrick. I'm a program coordinator here at the center. I see a lot of friendly faces. Thank you for coming. We have with us today Kristen Pearlstein, who is going to give us a wonderful talk about military medicine during World War I. If you haven't already seen, Kristen gave us a great presentation on military medicine during the Civil War, and that's on our YouTube web page. And I don't think you'll be disappointed today either. This is a wonderful, she showed me the slides and they're great. So Kristen is the Anatomical Collections Manager at the National Museum of Health and Medicine in Silver Spring, Maryland. She will present a 45-minute introduction to the challenges and the innovations of American military medicine during World War I. The National Museum of Health and Medicine was established during the American Civil War as the Army Medical Museum, a center for research that was related to battlefield trauma and pathology. The museum's mission is to preserve and explore the impact of military medicine, and it spans more than 150 years. Kristen's originally from the Charlottesville area. Her parents are members here at the center. We're very happy to have you and welcome, Kristen. Thank you so much.
Thank you. All right, I'm going to share my screen. Okay, this should be the right one. Now I can advance my slides. So this is me. Thank you for that great introduction, Carolyn. I have a PhD in anthropology and have worked with museum collections for 15 years. And some of my duties at the National Museum of Health and Medicine include taking care of our collection of anatomical specimens that date from the Civil War up through the modern era and include specimens from World War I. Carolyn also gave a great introduction to the museum, so I won't do that again, but I did want to add that during World War I, the museum sent detachments to Europe to document war injuries and diseases and to collect artifacts and specimens. And today I'm going to give a brief overview of some of the challenges and advances in US military medicine during World War I, particularly pertaining to the American Expeditionary Forces, or the AEF, which were the forces that were actually there in Europe. So a brief timeline to start us out. World War I starts in the summer of 1914, following the assassination of Archduke Franz Ferdinand of Austria. Austria-Hungary declares war on Serbia, and because of various international alliances, the conflict escalates to include most of Europe. On one side, the primary alliance was Germany, Austria-Hungary, and the Ottoman Empire, and on the other side was Britain, France, Russia, the United States, and a bunch of other countries. The US stayed out of the war until 1917, so there was a lot of death and carnage that occurred in the 3 years before US involvement, including the sinking of the Lusitania and the subsequent death of 128 US citizens by a German submarine. US troops began arriving in Europe in the summer of 1917, but didn't join the trenches until October of 1917. As the US was entering the war, Russia withdrew from the war to deal with its own revolution. And then a year later, the war officially ends on November 11th, 1918. So US is really only involved in actual battles of the war for about a year. Toward the end of the 19th century and during the beginning of the 20th century, there were a number of advances in military and civilian medicine that strengthened the Army Medical Department prior to going into World War I. These included the wide acceptance of germ theory and the ability to identify bacteria through microscopy, which aided in diagnosis of disease, the standardization of vaccination programs and vaccine requirements, the use of general anesthesia to put someone completely to sleep, allowing for longer and more invasive surgical interventions, and the use of radiology for X-rays, use of radiology and X-rays for diagnostic purposes. Some particular challenges that US troops and medical professionals faced during World War I include disorganization and lack of preparation in the medical department for the scale of the war, overcrowding in training camps in the trenches, malnutrition, exhaustion, and other stressors that affect physiological health, diseases pertaining to overcrowding, lice, fleas, and flies, artillery, shrapnel, and machine gun wounds, gas warfare injuries, and of course, the influenza pandemic of 1918 and 1919. And I'll briefly touch on most of these points as we move through the slides. An organizational change that strengthened the Army Medical Department prior to 1917 was that the department divided officers into 5 corps, including the Army Nurse Corps, which consisted of about 400 active duty nurses at the beginning of the war, but increased to over 20,000 by the end of the war. Nurses served primarily in base and evacuation hospitals and on transport boats and trains. The American Red Cross also provided about 8,000 nurses who served in base hospitals in England and in France. And I just want to point out this one photo in the lower portion of the screen where it says that a piece of artillery landed very close to the nurses. They just look so calm, and I think that's super interesting. Another corps was the Dental Corps, which provided first aid dentistry, performed minor oral surgeries, served as auxiliary medical officers, and made up half of each maxillofacial surgical team. We also had the new Army Veterinary Corps, which oversaw food inspection and the medical care of animals, particularly the horses and mules used for transportation. Medical care included treating gunshot and shrapnel injuries, treating poison gas injuries, and treating conditions like mange. So a lot of the same injuries that the humans were undergoing, and then hopefully the humans did not have the mange, but you never know. The last 2 corps were the Medical Corps for career medical officers and the Medical Reserve Corps to familiarize credentialed civilian physicians with military medicine in times of peace, so there'd be less chaos and confusion when these civilian physicians were called up to serve in times of war. One of the strengths of military medicine going into World War I, compared to previous wars, was a greater emphasis on preventative medicine. Sanitation was always a challenge in the crowded training camps, but was vastly improved by sanitary inspectors, sewage management, such as toilets that actually had lids that closed, and water purification. There was a better understanding of how flies spread diseases like typhoid and dysentery, leading to an emphasis on fly control and elimination of waste and sewage. In this image in the upper right, you can see enclosed garbage bins, a fly trap, and a sign that reads, "Swat the fly." There was also a better understanding of how rats and lice spread diseases like typhus, so several camps had delousing chambers. Unfortunately, there was no standardization between camps, and reports coming back from Europe indicated that half of the arriving troops were infested with lice due to the crowded nature of the transport ships. This image in the lower right is of an embarkation camp in France and the delousing of arriving servicemen. Venereal diseases such as gonorrhea and syphilis were a rather serious problem, particularly in arriving new recruits, and resulted in a large number of medical discharges. So the Army was aggressive with educational messaging, surveillance, and use of chemical prophylaxis. And this is an example of an educational poster trying to scare people away from venereal diseases and prostitution. One of the highlights of military preventative medicine was a successful reduction or elimination of typhoid fever and tetanus. During the previous major military conflict of the Spanish-American War, diseases such as yellow fever, malaria, and particularly typhoid killed 5 times more individuals than combat. An anti-typhoid vaccine was first developed at the Royal Army Medical College in Britain in 1896. In the early 1900s, the British success with the vaccine caught the attention of US Army Medical Museum curator Lieutenant James Carroll and his successor, Major Frederick Russell. Major Russell improved upon the British vaccine in 1909 through clinical trials using volunteer staff from the Army Medical Museum. By 1911, as a result of the successful clinical trials, the typhoid vaccine was compulsory for the whole Army, making the US Army the first military branch in the world to be vaccinated against typhoid. However, there were still a small number of diseases that did not have developed vaccines and for which antibiotics were not yet invented, including measles, mumps, diphtheria, chickenpox, meningitis, and pneumonia. These diseases could spread very quickly through crowded camps and barracks. To illustrate the combined effectiveness of inoculation and improved sanitation, there were only 1,200 cases of typhoid in the American Expeditionary Forces compared to 82,000 cases of mumps. And the last improvement on this slide is the near elimination of tetanus infections from contaminated traumatic injuries. A tetanus vaccine wasn't developed until the 1920s, but a tetanus antitoxin was developed in 1890 that could protect against tetanus for several weeks after exposure. During World War I, military doctors experimented with dosage and using the serum as both treatment and prevention of tetanus with excellent success. Something that the Army Medical Department learned during the Civil War was that swift evacuation from the field and early medical treatment was critical to preserving life and limb of injured service personnel. The World War I military medicine evacuation system drew on the evacuation practices of the Civil War and also the best practices of the French and British armies. This diagram maps out the hospitalization and evacuation system of each division, which essentially consisted of organized stretcher bearers and a relay system of medical care. Regimental stretcher bearers received first aid training for the first time in US military history and were responsible for removing injured personnel from the field and transporting them to aid stations or hospitals. Ambulances transitioned to motorized vehicles for the first time in military history, although horse-drawn ambulances were still used in areas of rough or muddy terrain. Horses also had their own ambulances, which you can see in this picture in the lower right. The first stop for medical care was a battalion aid station, which was located approximately 500 to 1,500 yards behind the front lines. These stations were meant to be mobile and temporary and were responsible for quick first aid treatments, not prolonged care. Battalion aid stations were the first point of triage, which was important for directing a patient towards specialized care down the line, depending on the nature of their injury, so each patient had a field medical card filled out that would stay with them as they traveled the medical system. And this is an example of a field medical card and the fields that would be filled out as the patient traversed the system. The second stop was an ambulance section dressing station, which was about 300 yards farther back from where the battalion aid stations were set up. Dressing stations were also intended to be points of emergency care, but could allow for slightly more time for the treatment and classification of injuries for specialized care down the line. As you can see from these images, the medical department made use of whatever space they could find close to the front. From the ambulance section dressing station, injured personnel were transported to field hospitals, which were located about 2 to 4 miles farther back. Each infantry division had 4 field hospitals, which started out identical, but by 1918, the medical department started to experiment with having specialized hospitals. The wounded and gassed went to one hospital, the sick went to a second hospital, skin and venereal diseases went to a third hospital, and the fourth hospital was for overflow and convalescence. Field hospitals were also points of triage for medical care down the line. From field hospitals, the next stop was an evacuation hospital. Each infantry division was supposed to have 2 evacuation hospitals, but the medical department ended up not having enough personnel to staff the hospitals, so there ended up being about 30 evacuation hospitals in operation. The evacuation hospitals were the emergency hospitals of the battlefield and were set up for quick surgical care. From evacuation hospitals, patients were taken by trains or hospital ships to large base hospitals in France, England, or the United States. These transportation vessels were set up with the personnel and equipment to continue medical care on board. And then the final stop in the medical evacuation chain were the base hospitals, which were located off the battlefield in France, England, and the US. These hospitals either took over large buildings such as schools or consisted of a campus of temporary buildings and tents. Base hospitals were often specialized or had a number of specialized wards, so injured personnel could receive targeted treatment by medical experts in the fields of orthopedic surgery, maxillofacial surgery, neurosurgery, neuropsychiatric care, contagious disease, gas injury, or influenza and pneumonia. In addition to the medical department-based hospitals, the Red Cross operated 24 hospitals in France and 20 medical facilities in England, particularly in cities the American Expeditionary Forces did not have established hospitals like Paris. Nearly 5 million US military personnel served in World War I, with nearly 3 million serving overseas and less than 1 million seen serious combat. Of these numbers, about 53,000 died in combat or from combat-related wounds. 63,000 died from disease, with about half of that number from the 1918 influenza pandemic. And over 200,000 were wounded but survived. So the total number of American casualties that is usually reported is 320,000, where casualty means both injuries and deaths. To put this in perspective, in the first 4 months of the war, France had about 300,000 deaths and 600,000 injuries. A large number of injuries during World War I were the result of chemical warfare and exposure to poison gas. The Hague Declaration of 1899 and the Hague Convention of 1907 banned the use of poison gas by European countries, but that didn't stop Germany from using poison gas on April 22nd, 1915. Once Germany started with the gas, other armies on both sides quickly followed. Chlorine gas was introduced first, which targeted the lungs and damaged the eyes and could result in death if inhaled. Phosgene gas was introduced later in 1915 and was often combined with chlorine gas. Phosgene gas caused respiratory and heart failure, and these gases combined were sometimes referred to as the suffocating gases. Nitrogen mustard gas was introduced in July of 1917 by the Germans and caused more chemical deaths and injuries than the rest of the gases combined. Mustard gas caused blisters and burns of the skin, attacked the respiratory tract, and attacked the mucous membranes of the eyes, nose, and mouth. In the picture on the left, you can see an example of blistering after the experimental application of mustard gas to the skin. In the middle is a watercolor painting illustrating the depth and color of mustard gas burns. Since color photography was not yet invented at the time of World War I, watercolor illustrations were an important way of documenting the extent of tissue damage. And then the picture on the right shows a tongue, larynx, and trachea exhibiting evidence of mustard gas inhalation. The larynx and trachea show a yellowish, frothy mucus due to tissue death of the mucous membranes. By 1917, 1/3 of all artillery shells contained gas, often mustard gas, and as a result, gas injuries account for 30% of all casualties, or approximately 100,000 injuries and 1,500 deaths. The treatment for chlorine and phosgene gas was bed rest. Mustard gas had to be thoroughly washed out to avoid further damage. And the 1925 Geneva Protocol banned the use of poison gas again, and so gas was not used in World War II. In terms of traumatic injuries, about 70% of all battlefield trauma resulted from exploding artillery shells, and about 30% from machine guns and rifles. Shrapnel from artillery shells caused a lot of tissue damage and carried foreign debris like dirt and clothing particles into the wound, so infection was a constant issue. And before I move on to the next slide, I just want to mention that there are pictures of an anatomical specimen that some might consider a little bit graphic in nature. There's no blood, but brace yourself as necessary. These two trauma specimens were donated by Major James Kupel, an assistant surgeon with the American Expeditionary Forces. Major Kupel served in the 26th Division AEF, stationed near Verdun, France. It's likely that this individual was injured during the Meuse-Argonne offensive, which occurred from September 26, 1918 to November 11, 1918, and involved 1 to 2 million US troops and resulted in the deaths of 26,000 US servicemen. These two sections of the same lower leg are from an individual who was injured on October 27, 1918 by a 37mm artillery projectile which exploded on contact. The soldier was observed in the admitting room, Evacuation Hospital number 6, walking around, smoking, talking loudly. He had a cloth tourniquet tied above his knee, and you can still see the imprint from that tourniquet here in the flesh. The leg is badly fractured, and because he was walking around on the fracture, examiners determined that he was likely in an excited state of shock. He underwent about 4 hours of treatment for shock and then underwent an amputation about 21 hours after the initial injury. As you can see, there's a fair amount of internal and external tissue damage. Just studying the fracture was not an option because gas gangrene was already starting to affect the traumatized tissues. Gangrene is a term that refers to tissue death or necrosis. Gas gangrene is a bacterial infection. It is not an effective poison gas. Bacterial agents infecting a wound produce toxins that release gas and cause the tissue necrosis. Necrosis can occur quickly and spread throughout the body to include major organs, so surgeons couldn't delay treatment. For projectile or explosive traumatic injuries, like this case, bacteria is frequently introduced into the wound with embedded soil or clothing particles. And gas gangrene and bacterial infections continue to be a significant concern for the treatment of injured military personnel. Modern military health officials are exploring ways to prevent particles of soil and clothing from contaminating injuries from high velocity projectiles. And we don't know the identity of this particular individual, but amputations during World War I only had a 5% mortality rate compared to 25% during the Civil War. So there's a good chance that he survived and went on to lead a healthy, productive life. Mortality rates for traumatic injuries or amputations were lower than any other of the previous wars because of dramatic improvements in wound treatment and management. There was a multi-step process following the assumption that all wounds were infected. A regimen of anti-tetanus serum was administered immediately upon reaching a battalion aid or dressing station, and as a result, there were only 23 cases of tetanus in the AEF. By 1917, debridement, or the complete removal of damaged and necrotic tissue, was a standard of care. The Carroll-Dakin system of antiseptic wound irrigation reduced bacteria and subsequent infections and remained a standard of care until the discovery of penicillin in the 1940s. Intravenous fluids were available, but were primarily used to treat shock. The US Army started to experiment with blood transfusions, but those did not become standard until World War II. With the wide acceptance and understanding of germ theory came a better understanding of the importance of aseptic surgery with sterilized instruments. Aseptic surgery was largely impossible near the front, but sterilization was routine in the hospitals. Also, combat surgery was performed by trained surgeons, which was a change from the Civil War when a large number of operations were performed by contract civilian doctors without trauma experience. And this image is of nurses sterilizing equipment at a base hospital. Surgical care advanced through the use of highly trained surgeons and the advantage of 3 years of observation of the experiences of the French and British medical departments. Orthopedic surgery shifted from an emphasis on splinting and amputation toward an emphasis on early surgical intervention. Through the combination of wound management and wound intervention, the mortality rate for femur fractures dropped to 15%, whereas some other armies experienced mortality rates as high as 80%. The use of general anesthesia and antiseptic techniques allowed for longer and more invasive exploratory surgeries, and as a result, abdominal surgery and craniotomies became routine. For abdominal surgery in particular, surgeons discovered that they had a better rate of success when surgery occurred as soon after injury as possible, whereas before, surgeries were often delayed past the point when shock and infection were already an issue. Maxillofacial surgery and reconstructive surgery addressed cases of face and jaw injuries from gunfire, exploding shrapnel, and burns. These cases were generally concentrated in a few select hospitals to maximize the expertise of a group of maxillofacial surgeons, dental surgeons, artists, and prosthetic experts. Reconstructive or plastic surgery using healthy skin to repair damaged areas was a newly developing field, and a lot of work at this point was trial and error. And this picture in the lower right is an example of an early case of plastic surgery. When the US entered World War I, the Army Medical Department had no portable X-ray machines and no X-ray specialists. X-rays had been previously used by the US during the Spanish-American War, but were largely dropped as a diagnostic tool after that. Coming into World War I, the medical department observed that the French and other European allies had successfully used portable X-ray machines since 1914. Surgeon General Gorgas established the Army Division of Röntgenology in 1918, and military radiology emerged from the war as a specialty in the US. Radiographs were particularly helpful for visualizing fractures for repair and shrapnel fragments for removal. The Army Medical Department struggled with the diagnosis and treatment of the neuropsychiatric condition described as shell shock. Shell shock was usually diagnosed through observations of shaking or trembling, paralysis, inability to concentrate, memory loss, confusion, sleep disruption, and pallor changes. Sometimes additional symptoms included tinnitus and a headache. The initial theory was that patients were suffering from a traumatic brain injury after exposure to exploding ordnances. But as the war progressed, there were an equal number of cases that occurred in men who had not been exposed to blast forces. To explain these cases, a theory advanced that shell shock was a psychiatric disorder of emotional weakness or cowardice. Reports described it as, quote, a disease of the emotionally unstable. Since this theory did not incorporate an aspect of physical injury, treatments often revolved around the idea that eventually the soldier could be returned to the field. The treatment used by the American Expeditionary Forces followed 5 rules. Begin treatment early, treat soldiers close to their units, expect the soldier will recover, keep treatment simple with warm food, fluids, and sleep, and keep the treatment consistent. More extreme treatments included the use of electroshock therapy to stimulate paralyzed senses. Now we know that shell shock probably incorporated both individuals with traumatic brain injuries and individuals with what we might describe as post-traumatic stress. We also know that PTSD has nothing to do with emotional weakness or instability, and that this theory is stigmatizing and damaging. We are constantly learning more about the causes and effective treatments for PTSD. And we can't talk about World War I without talking about the 1918 flu pandemic. As I mentioned earlier, the number of American World War I casualties due to disease and infection was higher than combat casualties due to trauma. In part, this was due to the 1918 influenza pandemic, which accounted for approximately half of all US military deaths from disease. You may have heard the 1918 flu pandemic referred to as the Spanish flu. This is because Spain was not involved in the war and was not engaged in the same level of censorship that other governments were engaging in. When Spain reported on a huge outbreak of influenza, it was the first time most people in the world heard about the pandemic. In the US, the severity of the situation was downplayed by government officials and military leaders to maintain social order and morale. The 1918 influenza was caused by a novel strain of influenza A. Influenza A naturally occurs in birds and other animal hosts and can mutate to affect humans. When a novel or new type A virus emerges, it means that humans have not been previously exposed or built an immunity to the virus. The virus is able to spread quickly and efficiently through the human population. The other influenza virus is type B, which is rarer and mutates more slowly. Influenza viruses are not responsible for the COVID-19 pandemic, which is caused by a novel coronavirus, a different group of viruses that cause respiratory illnesses. In the US, the 1918 flu pandemic first appears at Camp Funston in Fort Riley, Kansas in spring of 1918. It's possible that this is actually where the flu originated. You can see on this graph up in the upper right corner that there are normal levels of flu and pneumonia circulating around Camp Funston until March of 1918, and then bam, cases skyrocket here. Ultimately, there are three waves of the pandemic: the spring of 1918, the fall of 1918, and the winter of 1918 into 1919, with the fall surge between September and November of 1918 being the most severe. For the military, one of the most problematic aspects of this particular novel influenza was that it was most fatal in individuals between the ages of 20 to 35, which happens to be the prime age of most soldiers. Additional factors for the military included how the crowded conditions of camps, trenches, and transportation vessels and the constant troop movements facilitated the rapid transmission and spread of the virus. By the fall of 1918, nearly 1/4 to 1/2 of the Army and Navy were sick. And I just want to point out one detail of this picture, which is that almost everyone is wearing masks. This slide is to illustrate what was happening in the body with regard to the lungs and the respiratory infection. 95% of individuals who died during the 1918 flu pandemic died of secondary pneumonia, which is a serious complication of influenza and respiratory infections. On the left, we have an example of lung consolidation, which is this solid-looking area with the arrow. During consolidation, the areas that would be filled with air are instead filled with pus, blood, or dead cells, which limits airflow and the ability to breathe. On the right, we have an example of red blood cells and fluid filling the alveolar spaces, which is why the lung is this reddish color. And these are the same types of lung changes that we're seeing with the novel coronavirus. In the American Expeditionary Forces alone, there were nearly 200,000 cases of influenza and 13,000 deaths. Army-wide, there were 30,000 deaths and then 5,000 deaths in the Navy. In the US, the civilian population experienced 675,000 deaths, and approximately 1/4 of the US population was infected at some point. And remember, there's no antibiotics available to treat secondary pneumonia at this time. So all physicians could really do was keep the patient comfortable and wait. This picture was taken at Camp Funston sometime in 1918. And you can see again that the medical personnel are wearing masks. So I've talked about preventative medicine, and I've talked about trauma and disease as part of military service. And the last piece of experience I want to touch on is the rehabilitation and recovery process. The print on this image is tiny, but it basically outlines the plan of the Army Medical Department for reconstruction and rehabilitation of disabled soldiers. The path goes from clinical examination to placement in an appropriate hospital, to targeted medical treatment, to curative workshops that implement physical and occupational therapy, to vocational schools that trained individuals in marketable skills, to job placements and continued support. The large number of returning amputees helped transform the field of prosthetics, similar to the years after the Civil War. After World War I, there were approximately 41,000 post-war amputees living in the US. Rehabilitation had an emphasis on living productively and was geared towards getting injured soldiers moving as early as possible. In general, prosthetics advanced to be lighter weight, more durable, and more standardized. Specialized prosthetics were also designed to meet specific vocational needs, such as this prosthetic limb in the upper right corner here that has been adapted for use specifically in welding. Because most soldiers who received medical care survived the battlefield, there were a greater number of individuals who survived with a major injury. To address the growing number of men needing rehabilitation assistance, physical and occupational therapy emerged as a recognized medical field physical and occupational therapy emerged as recognized medical fields that were permanently retained as part of Army medicine. These images show a number of occupational activities designed to engage the mind and improve strength, flexibility, and dexterity, such as knitting in the upper right-hand corner, and typing on a typewriter here in the lower left. The lines between occupational and physical therapy and vocational rehabilitation were blurred at the time, but in general, all activities were geared towards supporting the soldier in life after the Army. This image in the upper left is of a blind patient learning how to tune a piano as a possible post-Army career. This image in the lower right shows a group of disabled men learning how to operate telegraphs. Some tools that were developed as occupational therapy during World War I have continued to evolve, such as art therapy, which today is utilized in military medicine as part of a holistic trauma treatment for traumatic brain injuries and post-traumatic stress disorder. On the right is an art therapy exhibit that the National Museum of Health and Medicine takes part in each year with a creative arts program at the National Intrepid Center of Excellence at Walter Reed Hospital. Which brings me to the end of this brief history. In summary, I'll use the observations of William Keene, who was a pioneer in neurosurgery during the Civil War and was the only surgeon to serve in both the Civil War and World War I. He was like 90 or something. And after World War I concluded, Keene wrote that some of the greatest advances in military medicine during the war were improvements in wound management and antiseptic techniques, improved sanitation, preventative medicine, and new surgical or diagnostic tools. And these are some of the sources that I used to put together today's presentation. And the museum is still closed, but you can follow our activities through our website, which regularly publishes informative blog articles, or through any of our social media channels. And hopefully we will all be returning to normal soon, and I hope you'll come visit me. And I will stop sharing now.
Wow. Thank you, Kristen. So I've unmuted folks and I see somebody. Barbara, did you want to ask a question or comment?
Yeah, I have a couple of questions. First of all, between the Civil War and World War I, your amputations, do you know how that improved time-wise?
Yeah, so the improvement in amputations, the process of amputation remained pretty much the same, but the improvements that aided with the amputation process were that they now had X-rays, so they could see where to amputate better. They could pick an appropriate spot to amputate. They could see if there was still shrapnel in there. And probably the biggest thing was that since they had the capability to prevent infection with sterilization of the instruments and then cleaning of the wound, more of those amputations did not get infected. So there was a better rate of survival and a minimization of the sort of chronic pain and infection that they saw during the Civil War.
Okay, another question I have is, I reenact the Revolutionary War, and my husband is the doctor in that process. Why don't you have anything on the Revolutionary War processes?
My museum was established in 1862 as a reaction to the Civil War. So we personally don't have anything from the Revolutionary War at the museum. But I'm sure that there are other museums that specialize in Revolutionary War medicine that I'm sure are great. It's just my museum happened to have started a bit later than the Revolutionary War.
Okay, thank you.
Yeah.
How do you, question from Susan in the chat, and I see someone else has a question, but hi, how do you know about the ambulances knee info? Ambulances knee info. AMBULANCESNY info.
Any information? I typed it wrong.
Oh, excuse me. I was thinking, go ahead, tell us what it is, Susan.
Well, my father drove an ambulance in World War I. Do you know anything about the ambulances, how they were organized or anything?
Yeah, there's a lot of documentation about the ambulances, about the medical department and the ambulance corps that is maybe more than I can say right now. But then there's like entire books that were written about it after World War I. And it was the first time that they switched to the motorized ambulances, which was exciting for everyone. So I don't know that I can personally speak to more about the organization right now, but if you wanted to email me, I could put you in touch with some of those resources.
Thank you.
And I see Stephen, did you want to?
Yes, thank you.
Sure.
How well or poorly were funds allocated by Congress in an effort to alleviate the suffering?
They put a lot of money into rehabilitation. One of the weaknesses that they had was in training. They were not prepared for the scale of the war. And so they didn't have the funds or the personnel to put enough people into the training camps that they really needed to get sort of the whole department up to speed and to have like all the evacuation hospitals open. There's a really great resource, which I'm trying to see if I have on my lap, but of course it's across the room. But the answer to that question is that they put some money in places where they should, and in some places they needed to do more and they weren't quite ready.
Okay. Wilkinson, Lossie Wilkinson?
Yeah.
Did you-
So what was the process of the delousing for the lights? What did that involve?
It pretty much involved them taking off all of their clothes, being sprayed down with some chemicals, which were probably not the best,
I know what had been the skin.
and then having their clothes be laundered and then returned to them on the other side of the delousing chamber. So it was not a fun process, but did help minimize the lice situation once they left the embarkation camps.
Thank you.
These are great questions. I had a clarifying question. When you mentioned about the Spanish flu, and you mentioned the the place in U.S. where it started.
Camp Funston.
Thank you. Did you say that that's where it actually may have started for everyone, or just in the U.S.? That was my question.
It may have started for everyone. Where the world is not sure yet where exactly it started. That's one of the questions that they're still sort of looking to answer about the 1918 pandemic. But one of the possibilities is Camp Funston because it did show up there so early in the pandemic. And one theory, because the particular strain looks somewhat familiar to swine flus, one theory is that it may have come out of the camp just because of contact near farms there, I guess, but they're not actually sure yet. It's just a possibility.
Wow, that was a new one for me. Thank you. Barbara, did you want to ask another question?
Yes. The chemical, the gas, poison gas, you said something about flushing it out of their system to help improve that. Did I hear that wrong? Or what did they do to flush it?
That is a great question that I don't actually know the exact answer to. I think that was about the mustard gas and how they had to wash it out of the wounds and off of their skin. I don't know what they used to do the washing, if it was a particular, if it was just water and soap, or if it was a chemical or what. But I know one of the reasons why they tried to get 2 individuals who had been gassed with mustard gas so quickly is because the mustard gas could actually continue to cause effects many hours after someone was first exposed. So someone might think in the first 4 hours that they were okay, and then they would start having reactions. So it was important that that they did sort of wash that gas off as quickly as possible.
So there was nothing that they actually did inside of the lungs.
I don't actually know. I don't actually know. I don't want to speak outside of my lane there. I do know that with the lungs, one of the issues was edema of the lungs and kind of necrosis of the tissues in there. And so that would have been very hard to address with any sort of, they couldn't wash that out without drowning someone essentially. So once it was in the lungs, like they wouldn't be able to flush it out.
Now, the difference between that gas, poison gas, and we'll say Agent Orange, is that kind of like the same thing?
I actually do not know the answer to that question.
Okay.
I'm putting that on my list of things to learn.
Okay.
Kristen, I do have another question. You mentioned that the French and British medical departments, that there was learning going on between and amongst. Would you say the US brought innovations and vice versa, or in your research, did you find out anything about how that communication was? For example, you mentioned, tetanus, that we did a great job with that, with the antitoxin. Were there any innovations or anything that we learned from other countries?
Yes, definitely. there was definitely a lot of back and forth and a number of things that we learned from the other countries. And I should have come with a list of things, because actually the surgeons of Britain and France were quite active before we got there and were working on a lot of the techniques, such as the abdominal surgeries and the craniotomies. And so some of those techniques we adopted, some of them we advanced through our own sort of medical surgeons. But I would say there was a lot of parallel learning that was happening between the three medical departments. And since they were in the war for 3 years before us, they did sort of have a head start.
Fascinating. Anyone else? Any comments or questions? Stories?
Well, we just thank you ever so much. It was ever enlightening to us. Never got that in school.
I have one more. Let me think of what it was. Smallpox. Okay, we know that Washington gave the first inoculations to the soldiers to test it out. How was the smallpox at the time, we'll say, of the Civil War and then the World War I?
By the Civil War, they were already inoculating against the smallpox pretty regularly. And in cases where there were outbreaks, then they isolated really quickly. So by the Civil War, they had the military had the smallpox situation more or less under control, like not completely under control, but more or less they were there. By World War I, smallpox inoculation was standard, and it was not really a problem at all.
Okay. Thank you.
Susan?
I always like to end on a positive note. And did I see a screen that you put up that said 95% were cured, or I missed the verb, by our military? 95% of the people that were received aid survived. Is that correct? Because that's an incredible number.
Yeah, that's the statistic that I read, and I think that speaks to the swiftness with which they were able to address traumatic injuries. That survivable injuries were more survivable for the first time in history than they'd ever been before. And so if they were able to get most of the soldiers to a field station and then to an evacuation hospital and then to a base hospital, then they had a better chance of surviving. Sometimes it could take a while to get to the base hospital. It could take anywhere from 4 to 17 days. And obviously that did impact the health and the capability to survive of those individuals that were on the longer end of that. But yeah.
Amazing.
Mm.
I keep thinking of Hemingway, but he served with the Spanish forces. I don't know, but
He drove an ambulance.
Oh,
but not for the AEF.
right.
Comment about the Agent Orange question.
Yes, Jonathan, hi.
Hi. Agent Orange, I'm a Vietnam veteran. Agent Orange was used in Vietnam, and it's a defoliant, not a poison gas. It was used to take the vegetation out for clearer views for a variety of reasons. The problem with Agent Orange was too many people got soaked in it or were exposed to it for long periods of time and caused nerve damage and other issues. It's not considered a poison, it's a defoliant.
Thank you for that.
Thank you for sharing that. It's good to know.
Mm-hmm.
I see my dad has a question about how prevalent mask wearing was in the general population during the flu. I know that there's statistics for that, but I don't happen to know them myself off the top of my head. So everyone go Google that and report back.
It is stunning that the age group that it really targeted, the 20 to 35-year-old population. I remember hearing someone say, that their grandmother was taking care of their grandson who was, hale and hearty, and then the next day, gone. So it was quite a stunning thing for a lot of people.
Yeah, and really unusual. Most respiratory viruses or flus don't have that pattern.
Mm.
How is your museum different from the one at Gordonsville?
I'm not actually familiar with the one in Gordonsville. Do you know the name of that museum?
I thought it was a Civil War medical museum. I've never been in it. I'm new to the area. So
Yeah.
I wondered, that's a goal to get to these different places.
So there's a couple different Civil War museums that I can think of. So in Frederick, Maryland, they have the National Museum of Civil War Medicine, which is actually a private museum. So it's not a federal museum, but we do have a lot of overlap. So my museum, even though it started with the Civil War, its mission is to document military medicine from the Civil War through the current period. The National Museum of Civil War Medicine is just focused on Civil War medicine and medical history for that time period. But we do share resources. And then I know there's another large Civil War museum in Richmond, Virginia, but I don't know if they are focused on military medicine at the time, or if they're sort of a more general Civil War museum.
Do you also carry correspondence? I have a friend back in California whose relative was a physician, and he found some of his physician relatives' correspondence. So do you have that type of things in your museum where you keep those documents for historical purposes?
We do, we absolutely do. We have a large archives division that keeps track of correspondence, medical reports, autopsy reports from Civil War up through World War I. So that is definitely a branch of our museum, is that archives division, and keeping those documents safe.
Wow, really worth exploring. I see the Pearlsteins. Did you have a question or comment?
No, I already asked it.
Oh, okay. All right. Thanks, Rana. Anyone else? Well, Kristen, thank you once again for spending all of that time and energy putting together a presentation that I'm sure educated us all about things, a lot of things I never knew about. And it's good to reflect on those. Anyone else? Last minute comments, questions for Kristen? Okay, well, thank you all for joining us. Go ahead. Oh,
thank you so much for having me back. It's been a pleasure speaking to you all.
We
great.
enjoyed so much learning from you. Thank you.
Thank you.
Mhm.